Now, the title of my talk is Time to Get Back to Basics. If you are on a journey and you lose your way, it is often advisable to retrace your steps, to return, if not to the very beginning, then at least to a place you know. If you plow on, trying to guess which route will connect you to the right path, you risk getting irretrievably lost. I believe we have lost our way in the healthcare sector, and it's time to go back to an idea from an earlier time and do now what we should have done then. One date that saw us decide upon the right path is 1978. That was the year of the Alma Ata Declaration, made at an international primary healthcare conference attended by 134 country delegations and scores of development partners and non-governmental organizations. It's a long document, but I recommend you read it. When you read it, you'll get a sense of déjà vu. So many concepts we're talking about today keep coming up. But one quote: a main social target of governments, international organizations, and the whole world community in the coming decades should be the attainment by all peoples of the world by the year 2000 of a level of health that will permit them to lead a socially and economically productive life. Primary health care is the key to attaining this target. Today, we're talking about universal health coverage, defined as all people obtaining the health services they need without suffering financial hardship. We should be aware that although the Director General of WHO, Margaret Chan, in 2012 at the World Health Assembly, called UHC the single most powerful concept that public health has to offer, it is not significantly different than what was proposed in 1978. And of course, it will require effective primary health care. But this is my question. If the entire global public health community agreed that primary health care is the way to equitably provide health services to our citizens, why nearly 4 decades later are we still struggling to provide basic preventive and curative health services across Nigeria? I believe it is a political problem, not a public health one exclusively. For decades, successive governments have paid only lip service to improving health. The politicians know that it's important to seem caring when they're campaigning, but they have worked out that they will not be punished by voters if they fail to deliver on that promise. Why? Because unlike the case with bad schools or roads or lack of affordable housing or employment opportunities, all of which can be blamed on government, a bad health outcome is deemed to be the will of God. In fact, the worse the outcome, death being the extreme, the more deep is the emotional need to look to God. So, God saves the politicians from the blame they deserve for neglecting healthcare services. Now, although providing primary healthcare service is relatively simple at the local level, making it happen in numbers that will ensure affordable access for most of the population is a major challenge. The purse strings are controlled by those who least understand healthcare as a system. Yet only a functioning, sustainably funded system can take PHC to scale. One tangible result of this is that we have hundreds of structures strewn across the country, uncompleted, completed but not used, used and then abandoned, buildings that were all meant to be primary healthcare facilities. They are standing like crumbling tombstones in a graveyard overtaken by vegetation, each one a testament to the doomed political strategy that equates the provision of healthcare services with the erection of buildings. In Ogun State, under Senator Ibikunle Amosun, we decided to see if we could overcome these deep-seated obstacles and actually begin to turn around primary healthcare. There is an interesting and perhaps amusing backstory to the evolution of this project, but that will be for another day or maybe at the bar. The plan was to decentralize control of facilities and unlock a sustainable flow of funds. This would be done by implementing a community-based health insurance scheme. We spent a long time, that is myself and the members of the Primary Healthcare Board team, brainstorming all the details of the scheme and consulting as widely as possible and conducting the necessary research. And we had help from federal government, including the NHIS, I'm happy to say, and many partners. We came up with a plan for a state and local government subsidized scheme that would cost each enrollee 4,000 naira per year, with government contributing 3,000 naira on top. We will provide significant value even for those who might not use the scheme because of not suffering from ill health. So there will be health checks, there are health checks, free screening, HIV counseling and testing, health promotion activities, free commodities, and so on. We also have an equity fund to enable the scheme to cater for the poor for free, and of course also the usual groups, pregnant women, children under 5, and the elderly. They would also be enrolled for free. The benefit package would include treatment of common infectious diseases, antenatal care, delivery and postnatal care, and treatment of uncomplicated NCDs like diabetes and hypertension. We would also put every participating clinic on a quality escalator and ensure a strong focus on quality improvement on the supply side. It's absolutely critical for maintaining enrollment. The scheme administration would make substantial use of IT to increase transparency and eliminate fraudulent use. Both public and private clinics would be eligible to participate. Well, we launched the scheme, we called it Araya, that's Healthy Body, at the end of April last year. We are working with a selected group of HMOs to reduce the administrative burden on the Primary Healthcare Board. And most importantly, the communities have been engaged from the outset. Each sub-scheme has a board of trustees drawn from the local community, usually active CDA members. The BOT members receive training and a small stipend. No plan or decision is made without their input. The scheme is therefore driven at the local level by motivated community members who are empowered by means of a regular income by way of capitation fees. It is still in the pilot phase. Our takeoff has been slow. We have over 50,000 registered enrollees in 6 local governments. That's what we're limiting the pilot to, and we intend to rigorously conduct the pilot and then scale up, having learned the lessons and fine-tuned. The biggest obstacle, sorry to say, has been to get the government part of the subsidy actually paid. However, the sustainability, I believe, has manifested clearly by the scheme growing despite the current financial problems affecting Nigeria and therefore affecting our state. So far, the results are looking promising, and the scheme will be rolled out statewide after we have finished our fine-tuning process. So importantly, however, it's not just about insurance. And when I tell people that, what's your big thing, what are you doing, and I mention insurance, you can see the eyes glaze over. But it's an engine. I talk about the system, and it's about systemic thinking. The scheme provides an efficient framework for the rapid piloting and adoption of best practices. We have included conditional cash transfer for pregnant mothers in the scheme. We're trying commodity exchange. That's for farmers and fishermen. They can actually have a market and then use their commodities for health vouchers. We are trying mHealth ideas and other ideas under a technology leapfrogging scheme being driven by the World Economic Forum. And we are also actively pursuing a variety of ways of expanding contributions to the risk pool, with some success, for example, from charities and philanthropists. No doubt, in the future, innovative tax mechanisms will play a part, but whatever the optimum solution, we have the framework to test it. So, with promised extra finances coming courtesy of the National Health Bill, all indications suggest that this model or variations of it can successfully revitalize primary health care. I am more convinced than ever that we must build our health service on a sound, sustainable foundation of primary health care financed in part through community-based and other forms of insurance. With communities so closely involved statewide, it will no longer be safe for the governments to neglect health and rely on them giving God the credit. So if they fail to pay their subsidy, it will hit them where it hurts at the election time. Communities will know their health rights, and this is the key. We need to have proper demand of health rights, and a scheme that includes health promotion and involves the community will achieve this. So, in conclusion, 2018 will be the 40th anniversary of the Alma Ata Declaration. It must not meet us in this atrocious condition. So let's get back to the basics as outlined in the Declaration and the conference recommendations. I believe the future healthcare service that we want in Nigeria is dependent, totally dependent, on a foundation of primary healthcare which can be rapidly and sustainably revitalized by well-designed, state-supported health insurance schemes. And I believe we can do this by the year 2018. Thank you.